Good evening. In last class, we were discussing about the lie and presentation of the fetus. Is everything was clear? What is lie? What is presentation or presenting part? Presentation is the denominator, like in cephalic presentation, it is cephalus towards the lower part or the vaginal part of the female. And lie is relationship of the vertical or the spine of mother and fetus. The longitudinal lie, vertical lie, diagonally. So all those were regarding to the fetus. And what the changes mother go through, that we'll discuss today. Was everything clear in the last class?
Ma'am, I have a query, ma'am.
Yes.
Ma'am, by knowing this presentation or lie, all those things, there is a line that we come to know the amount of liquor amni. How is that, ma'am?
Yes, today we'll go to discuss further about the assessment and diagnosis of the pregnancy. That we'll discuss further. And for the liquor amni, by manually we can diagnose, or in the USG reportings, we'll know exactly the amount of the liquor. That you need technical support, but a rough idea you will get through the per-abdominal examination also. But if you are very expert, with the expert hands only. So
Okay,
let's
ma'am.
start. Let's diagnosis of pregnancy and maternal assessment. What are the presumptive signs of the pregnancy? First of all, amenorrhea, menstrual cycle. The bleeding phase in the menstrual cycle disappears, and other changes like breast changes, signs of nausea and vomiting, amenorrhea, that is no menstrual bleeding, frequent urination, fatigue and uterine enlargement, quickening, linea nigra, melasma, and stria gravidarum. The last three signs are due to the skin changes, due to abdominal pressure, quickening, that is signs of movement of fetus, fatigue and uterine enlargement due to the developing fetus, frequent urination due to developing fetus, pressure was there on the urinary bladder, amenorrhea, cessation of menstrual bleeding, and nausea, vomiting. These are the system due to the systemic changes and hormonal changes, and in breast changes due to the development of pituitary glands for the lactation further. There's the heaviness, hardness, and sometimes it is tenderness also, and blood supply, all these changes. So these are the presumptive signs of the pregnancy. And what are the probable signs of pregnancy? Chadwick signs, Goodell sign, Hager sign. All these can be done manually by per vaginal examination or per speculum examination, and evidence of ultrasound of gestational sac, ballotment, Braxton Hicks contraction, and fetal outline felt by the examiner. Now, positive signs of pregnancy. If female is conceived, fertilization is done. What are the live presentation of fetus? We gone through. But how can we diagnose that pregnancy, or what are the signs and symptoms of that pregnancy? So demonstration of the fetal heart separate from the mother heart is the positive sign of pregnancy, but this is not present in the early stage of pregnancy. It is there in the second trimester, and that also in the second half of the second trimester. Pregnancy is divided into three parts: first trimester, second trimester, third trimester. That is sum up of a set of 3 months. Fetal movements can be felt by the examiner, and visualization of fetus by ultrasound. These positively denote towards a pregnancy. That it's confirm that. First trimester. I think it is missing here, division of trimester. In first trimester, what are the subjective symptoms? subjective, that is felt by the pregnant lady herself. So it is amenorrhea. There is no bleeding during the menstrual phase. Morning sickness, comfort during morning. Frequency of micturition, as I told earlier, due to the pressure on the urinary bladder, this symptom is there. Breast discomfort and fatigue. And what are the objective signs that is examined by the examiner? Breast changes. As you see, differences in the breast of the pregnant, non-pregnant females, and in pregnancy also changes in the early and late pregnancy. So breast changes are there. For abdominal signs, pelvic changes. There are Jacquemus sign during the 8th week. Vaginal sign, it is Osiander sign in the 8th week. So these are usually asked in the frequently asked questions in many of the competitive exams also related to this field, that when you will go to the Jacquemus sign or Osiander sign, so timings are approximately by 8th week. And for the cervical sign, Goodell sign, it is by 6th week. We'll discuss about these signs in detail also, but for now, we'll just go through the signs and symptoms, then we'll discuss in detail. So by 6th week, the cervical sign is there, Goodell sign, and uterine sign, it is change in shape and consistency of uterus. Generally, we studied in the anatomy of uterus, that is ovoid in the shape, but some size and shape changes from the normal, and it go on changing. That is Piscata's sign. Hager's sign between 6 to 10 weeks, and Palmer's sign was the earliest at the 4 to 8 weeks. And other than that, immunological tests for the diagnosis of pregnancy are also there. These are direct agglutination test. Sensitivity is 0.2 in IU of HCG in per ml that we generally do. This is enzyme-linked immunosorbent assay. It is based on the monoclonal antibody that binds the HCG in urine and serum. So the level of HCG, that is human choreographic gonadotropin hormones, is measured via urine or serum to diagnose the levels of HCG to confirm the pregnancy. During pregnancy, HCG levels rises. The pregnancy test, that is to diagnose the pregnancy, we do the urine test, that is also test for the HCG, and the sensitivity is 0.2 international unit of HCG per ml. So it is a kind of ELISA test. Antibodies bind with that HCG, and it shows the levels of HCG and confirm the pregnancy. In other than pregnancy, HCG level also rises in some form of cancers, and it may be positive in males also in some cancers. So these are the other points, but you should know that. And direct agglutination test and ELISA. Fluoroimmunoassay is also there. The fluorescence emitted is proportional to the amount of HCG. It can detect HCG at low at 1 MIU per ml. Here it is 0.2 international unit can be observed by these above methods, but by fluoroimmunoassay, the fluorescence emitted, and it can diagnose HCG at very low level, but it takes timing of 2 to 3 hours to diagnose that assay. Immunoassays with radioisotopes, that is radioimmunoassay and immune radiometric assay. So these are the technical methods, and being a doctor, you should know that, but the main purpose of that is of our concern. And generally, the ELISA and direct agglutination test are in use. In very sensitive cases, other assays are helpful. Radioimmunoassay, it is more sensitive and can detect beta subunit of HCG up to 0.002 2 IU/ml in the serum, it can detect pregnancy as early as 8 to 9 days after the ovulation. So, just after the fertilization, by the time of implantation, may detect pregnancy. It requires 3 to 4 hours to perform. An immune radiometric assay uses sandwich principle to detect the whole HCG and require only 30 minutes. Selection of time by 8 to 11 days after conception. The test is not reliable after 12 weeks, but it is reliable up to 12 weeks only. And after that HCG levels, ultrasonography is also there for diagnosis. That is intradecidual gestational sac that develops by 29 to 35 days of gestation. Fetal viability and gestational age is determined by detecting the following structure by transvaginal ultrasonography. For abdominal, uh, also we can see the development of fetus, but in transvaginal, in early pregnancy, the transvaginal view is more clear or prominent, as the location of fetus is in the pelvic area only. So per abdominal, the things are advanced, but the view of the transvaginal ultrasonography is much more clear. And gestational sac and yolk sac is by 5 weeks of menstrual cycle. So in a month, a cycle is of approximately 4 weeks, and after that 4 weeks, the fertilization generally done after the second week, and you can take that 2 weeks post fertilization and 1 week that. So approximately by 3 weeks of the fertilization, the gestational sac and yolk sac are clear. But that doesn't mean the fetal sound or viability is measured by that. So after 1 more week, by 6 weeks, fetal pole and cardiac activity can be diagnosed by ultrasound. So if there is no cardiac activity at the fetus by 5 weeks, so you can't say that fetus is not alive. Sometimes the in the beginning of practice, many obstetricians may be confused that what to do. There is no sign of cardiac activity. So it is not the matter of concern. You have to repeat that after 1 or 2 weeks to confirm the cardiac activity, because it is cleared by USG by 6 weeks. And embryo development by 7 weeks. Fetal gestational age is measuring by CRL, that is crown to rim length. As we discussed in the last class, the length, that is length or acromion length, crown to rim length. So crown to rim length by mixing the fetal gestational age. These are generally the, if you see the ultrasound report of the obstetrics, you go through all these terms, and these are very important. The fetal heart is reliably by 10th week. And of the second trimester, the symptoms quickening at 16 to 8 weeks. So fetal movements can be felt in preemie-gravity, that is who is pregnant for first time by 18 weeks, and in multiparity, that is who are pregnant for many times by 16 weeks even. In general, at an average, it is timings of 16 to 18 weeks. It denotes the perception of active fetal movements by the women. Progressive enlargement of lower abdomen due to increase in size of fetus. For the general examination, chloasma, that is pigmentation over the forehead and cheek, may appear up at about 24th week. These are due to the changes in the liver and enzymes of that chloasma, and sometimes signs for mild itching are also there. These complaints are general. Now for the breast change, breasts are more enlarged with the prominent veins under the skin. Secondary areolas, specially demarcated in primigravity, usually appears at about 20th week. Montgomery tubercles are prominent and extend to the secondary areola. Colostrum become thick and yellowish by 16th week. Variable degree of stria may be visible with advancing. Now for the abdominal examination, linea nigra as early as 20th week, and striae are also visible. These are the due to the stretching of the skin and veins becomes prominent. So these are the linea nigra and striae by the 20th week. On palpation, fundal height can be felt. The height of the uterus is midway between the symphysis pubis and umbilicus at 16th week. At the level of umbilicus, at 28, 24 weeks, at the junction of lower third and upper third of distance between the umbilicus and ensiform cartilage at 28 week. So if it is umbilicus, so by 16 week, uh, the fetus, you can feel the bifurcation below the umbilicus at 24 weeks at umbilicus, and gradually it increases between the xiphoid cartilage and umbilicus. It is 28 weeks here. At 32 weeks, one third below the xiphisternum. At 36 weeks, towards the xiphisternum, and gradually it comes down of the 28 weeks by 40 weeks. So these are the important palpitation during the second trimester. On abdominal examination, the uterus feels soft and elastic. Braxton Hicks contractions are there. Palpation of fetal parts, active fetal movements, and external ballotment, that is feeling of the by palpating by the hands of the examiner also. Auscultation, that is fetal heart sound, is audible by a stethoscope. Uterine shuffle and funic and fetal shuffle are also there. So there are, other than fetal heart sound, uterine shuffle and funic or fetal shuffle is also there. So it is necessary to differentiate between these two. On vaginal examination, bluish discoloration and internal ballotment is observed. Investigations, sonography, that is routine sonography at 18 to 20 weeks, permits a dilated survey of fetal anatomy, placental localization, and integrity of the cervical canal. These days, the level 2 ultrasonography is very common to diagnose the internal parts of the fetus also. That is the anatomy of the other than the external parts, that is limbs and all that. The internal organs like liver, kidney, heart, all these are diagnosed whether it is developing properly or not. So routine sonography, and it is by 18 to 20 weeks. Routine sonography at 18 to 20 weeks permits a dilated survey of the fetal anatomy, placental localization, and integrity of the cervical canal. So it is also important to note down the integrity of cervical canal for the delivery further. Fetal organ anatomy and MRI. In the last trimester, symptoms are amenorrhea persist, enlargement of abdomen. With the developing fetus, the size of the abdomen also enlarged. Lightening is felt. Lightening is generally felt after the 34 weeks, because as the fetus is engaged, it goes down and some lightening is felt by the mother. Frequency of micturition increases. The same reason, as the fetal goes down, the pressure on the bladder increases and frequency of micturition increases. Fetal movements are also felt in the last trimester also. Signs, there are cutaneous changes, skin changes, linea nigra and striae are visible. Uterine shape is changed from the cylindrical to spherical beyond 36 weeks. Earlier, up to 36 weeks, it is cylindrical, but as the fetal descended down, it becomes spherical. Fundal height corresponds to the junction of upper and middle third at 32 weeks up to the level of ensiform cartilage at 36 weeks, and it comes down to the level of 32 weeks and 40th week because of the engagement of the fetus. To determine whether the uterus height is correspond to 32 weeks or 40 weeks, at 32 and 40 weeks, it is the same height, the fundal height is same. So how can you differentiate that the fetal age is by 32 weeks or 40 weeks? So for this, we can see the engagement of head. I'll explain you. You might be confused with that. I will explain you in whiteboard also once again. If I forgot, just remind me about that. Then it will become much more clear. And Braxtonic contractions are also there in last trimester also. Fetal movements can be felt easily. Palpation of the fetal parts. FHS sonography. Amniotic fluid is done to detect oligohydramnios or polyhydramnios. The answer of your question, the amniotic fluid index is detected actually. So if it is less than 5, then it comes under the oligohydramnios, and if it is more than 25, then it comes under the polyhydramnios. And it is done by the sonography. Differential diagnosis of pregnancy. These are the signs and symptoms of pregnancy, but sometimes it is confused with other changes like pseudocysts, cystic ovarian tumor, and fibroids, or encysted peritonitis. So, to differentiate between the pregnancy and these similar conditions, it is very important to be clear. And this can be done by the above methods as we go on to the trimester wise. Now, maternal assessment. Aim of the maternal assessment is to identify the high risk cases to prevent and detect and treat the earliest of any complication if there is any complication, like if mother is anemic. So if is she's already anemic, then how can she is able to supply the or fulfill the iron demands of the or the oxygen demands or the IVC demands of the fetus? Or if she's hypothyroidism is there, so metabolism is not proper in mother, then how it will helpful to nurture a fetus. So maternal assessment is also necessary. Or if hypertension is there, that is most common condition. Or sometimes diabetes mellitus or gestational diabetes mellitus is very common. So assessment is very important and aim to identify the high risk cases to prevent and detect and treat at the earliest any complications. If there is any complication, then it is prevented or detected at earlier, or if it is detected earlier, so if it is possible to prevent it, we suggest or advise a female to prevent. Or if it is not possible to prevent, then at least the treatment is started at earlier, as earlier as possible, to avoid any complications, to ensure continued risk assessment and to provide ongoing primary prevention health care. So if there is any kind of risk, you can counsel the patient as early as possible, and if it is required any primary prevention healthcare, then it is given. To educate the mother about the physiology of pregnancy, labor, newborn care, and lactation. This is the most important but most ignored part. To educate the mother about the physiology of pregnancy, labor, newborn care, and lactation. Uh, all these things must to be explained to the mother, to discuss with the couple about the place, time, and the mode of the delivery. And what are the mode of delivery, and when we are going to choose that, all things should be cleared earlier with the couple. Now, procedures at the first visit. The initial interview, that is demographic data, chief concern, family profile, present history, past history, obstetric history of a female. All these should be noted. Menstrual history, gynecological history, personal history, family history like family history of diabetes mellitus, hypertension, or any renal or cardiac disease. All these should be noted. Now, physical examination, baseline height and weight measurements. Very important to measure the height and weight of pregnant female. Vital signs like pallor, pulse, heart rate, head and scalp, eyes, nose, ears, mouth and oral cavity, neck, breast, thorax, back, rectum, extremities, and skin. All these should be examined and noted. Now, abdominal examination, preliminaries, inspection, and palpation. First, you have to observe by your eyes, inspect, and after that, palpate. And on palpation, you have to see the height of the uterus and obstetric grips. So here you can see in first figure that the grips along with the height is measured. So where is the cephalic part or the head of the fetus in the second figure, the back of the fetus, trunk, all these are palpated. These are the obstetric grips. And all after that auscultation by stethoscope or Doppler or many advanced techniques are there these days. The relationship of fetus to the uterus and pelvis, that all these lie, presentation, attitude, denominator, position, and presenting part. And I hope you are now aware of all these terms. In pelvic examination, external genitalia, first you have to observe the external genitalia, and for the internal genitalia, uh, by using the instruments or slightly by separating by the fingers, and vaginal inspection, examination of pelvic organs and estimating pelvic size, the diagonal conjugate, true conjugate, and ischial tuberosity. But it is not supposed to do the pelvic examination in the first trimester or up to the late of the third trimester if there is no complication or problem, because it is a good source of infection and may increase any problem. So if it is important, you have to do the pelvic examination, but if there is not such complication or problem, then it must be avoided. In laboratory methods, blood studies, that is complete blood count, genetic screening, serological test of for syphilis, blood typing, that is ABRH grouping, maternal serum alpha fetoprotein, indirect Coombs test, antibody titers for rubella, and or not only for rubella, but it is for generally for the torch, that is toxoplasma, rubella, cytomegalovirus, and herpes virus, and hepatitis B, HIV test, and glucose tolerance test. These must to be done. And along with that, the systemic investigation of the liver, at least by serum bilirubin level, or working of the kidney, at least serum creatinine must to be done, and urine analysis. What are the importance of ultrasonography in different trimesters? Here, in first trimester, it confirms the pregnancy, it confirms viability. Now, can anyone tell me that by how much week viability is confirmed? We just go through in previous slides. Viability is cleared by about 6 weeks. That is cardiac activity of fetal pole is clear. So in first trimester, determine gestational age, rule out ectopic pregnancy. Ectopic pregnancy is very common. So it can be ruled out in first trimester only. Detect multiple gestation if it is more than one fetus. So detect multiple gestation. Use for chorionic villus sampling. Detect maternal, confirm the date, confirm oligohydronias, that is level of the amniotic fluid. Detect congenital anomalies. Detected IUGR. IUGR is intrauterine growth retardation. So if there is any growth retardation, it confirms the placenta placement, visualization during the amniocentesis. In third trimester, it is to confirm the gestational age, confirm viability, detect macrosomia, detect congenital anomalies, detect IUGR, determine the fetal position. It is very important to clear the position during the third trimester. Detect placenta previa or abruptio placenta, that is location of placenta, visualization during amniocentesis, external version, And biophysical profile, it is measured by the 5 factors of the fetus, like movement, activities, and all that, and points are given. So can be done in the third trimester. And amniotic fluid volume that detect placental maturity. Now, components of ultrasound examination by third trimester, that is gestational sac location, embryo and yolk sac identification, crown to rump length, cardiac activity, fetal number, including all these similar kind of points we go through the last slide. And in the second and third trimester, there are mild differences during the second and trimester, third trimester, and the first trimester mainly. So these are the differences that fetal weight is important to note down during second and third trimester, but fetal viability is more important to note down during the first trimester. And during first trimester, we want to know that there is a single fetus or multiple fetus, but it is not important in second or third trimester because we already know that. So these are the differences or the components of the USG examination trimester wise. There is not so much importance of the fetal weight during first trimester, but it is important in second and third trimester. And fetal anatomical survey, fetus is not developed. Only cardiac fold or activity is shown in the first trimester, but in the second trimester and third trimester, anatomical survey is important, including documentation of technical limitations. And evaluation of uterus and instant cervix is very much important due to the timing of delivery is much more nearby the last trimester. So these are the differences between the second and third trimester. So sonographic evaluation, the standard specialized examination. It is a limited examination, neutral translucency, fetal biometry, gestational age, amniotic fluid, fetal weight, all these can be diagnosed and determined. And Shepard's formula and Hadlock's formula, these are the technical work specially designed for that. And the obstetricians get all these information or values from these formulas only. And special investigations in the case of high risk pregnancy, that is maternal serum alpha fetoprotein. It is not necessary to have these values in every pregnancy, but if it is high risk pregnancy, that is a high risk means there is several abortions in the previous obstetric history, or bad family history, or bad obstetric history. So it is important to have these, that is maternal serum alpha fetoprotein, triple test, acetylcholine esterase, amniocentesis, chorionic villus sampling, fetal movement count, chordocent